I usually, for me, there is mainly just one screw, and that's JS. And I'm very thankful to dual top system for having this type of screw. So I use mainly 90%, let's say, just the JS screws, different diameters, so from 2.0 to 2.5, and different lengths from 10 to 16. Why I choose these sizes? Because the diameter, the reason is all the studies show, most of the studies show about mechanical resistance of mini screws, show that screws above 2 millimeters diameter have a better stability, so they will not bend in the bone when we apply forces. And that's very important, because if the screw will bend when we apply the force, we will have bone resorption around the implant, and then that mini screw is prone to loosening, and we can lose that screw, and we can lose our anchorage. 2.5, it's mainly in the pterygopalatine area, so that's the only area where I use the 2.5 diameter, or in the tuberosity when we have poor quality bone. But it's a very strong screw, and usually I use it for when I want to distalize or intrude the whole upper arch, and it can give me a lot of support for the heavy forces that we need to intrude and to distalize the upper jaw. Rarely in the anterior maxilla I use the JA or the JO screws, because they have a round shape, and it's more comfortable for the patient. And beside mini screws, what I use a lot are the anchorage plates. And I love using anchorage plates because they give me a lot of support and a lot of stability. And usually I use plates for cases that otherwise I would be forced to use orthodontic surgery or choose another treatment plan, and not treat the case according to the diagnostic and to the to my point of view. When we talk about success rate, we can see that mini plates have a higher success rate than mini screws. And also sometimes we can use dental implants if the patient has dental implants, and those dental implants are very stable, because they are the dental implants, we all know they are enclosed in the bone, so we can use them very well, but we have to be also very careful to the information that we put on in that bracket that we place on the implant. When we compare the mini plates to the screws, we can see that the mini screws have the advantages are no flap required, easy removal. Disadvantage is prone to loosening more often than the mini plates. Complications for mini screws, potential damage to tooth roots, loosening and infection. And also the cost, it's lower than mini plates. For the mini plates, we have a very stable anchorage, applicable to most areas in the dental alveolar, because we don't place it in the dental alveolar area, we place it above the roots. So the screws that will fix the mini plates are above the roots, so the roots will not interfere. So they will be in the extra alveolar area, so it will not interfere with our movement. Disadvantages: surgery required for insertion and removal. And also another disadvantage is we will have more irritation, because sometimes the plates come out not in the fixed mucosa. It's very important when we ask the surgeon to place our plates to come out with in the mouth in the fixed mucosa. If the plates are coming out in the loose mucosa, then we will have some issues with the irritation and sometimes infection. Even if we have infection, we can treat them, and we can go on with our treatment even if they are a little bit loose. And very, very rarely I had to remove the plate, wait for 1 month or 2, and then go on, place again the plate, and go on with the treatment. So loosening and infection, loosening is not a big problem for plates, but infection it's more often than, and can be more complicated than mini implants. Cost also, it's an issue because it's a little bit higher. It requires a surgeon that will place and his fee. When we talk about mechanics, usually the most important thing in orthodontics is the treatment plan. So I like a lot to do my treatment plan in the 3 planes of space. So vertical, transversal, and sagittal. So all the problems will be placed in boxes that will be either vertical, either transversal, or sagittal. This gives me the opportunity to also choose better the mechanics, because what change we will make in the dental arch, doesn't matter if it's vertical, transversal, or sagittal. If we do any movement in one plane, it will also change the position of the teeth in the other plane. So in talking about occlusion, any change that we will do in one plane will change also the occlusion, and it will do modifications and changes in the other planes. So always we have to see our anomaly or our problem that we have, in which plane it's the bigger problem, and in which plane we can treat better that anomaly. Because sometimes we may have a sagittal problem, a class 2, but it might be a vertical issue because we have an excess maxilla, a vertical maxilla, so we had to intrude the maxilla, and that will change also when we intrude. The mandible will auto-rotate, and we will also self-correct the sagittal issue that we had. But we treated the case in the vertical plane. And also in the transversal, if we do any changes, we know if we expand the arches, the vertical will change and the bite might open. The sagittal changes, we all know if we distalize mainly, we will open the bite, so we will increase the vertical. If we mesialize the teeth, we will decrease the vertical. So we have to be careful with our treatment planning. It's what we want to obtain, what's our bigger problem, and what we want to obtain, and what changes do we want to do in our planes. Talking about vertical, when absolute anchorage is needed, we will use intrusion in the anterior or posterior teeth. So intrusion in the anterior teeth in cases of over-erupted incisor, absolute intrusion of posterior teeth in cases of patients with increased anterior facial height or extruded posterior segment, absolute intrusion of entire maxillary arch in cases of patients with maxillary vertical excess, or intrusions of localized over-erupted teeth in cases of absence of antagonists or ankylosis of antagonists. And also extrusion of anterior or posterior teeth when we need it. I would like to present some cases. I will talk first about intrusion in the anterior teeth. This is a deep bite case. So we have a sagittal problem, but we have also an important anterior vertical problem. We will lose the 22 because it has endo issues. And we can all see it's a narrow maxilla, but it's not a bony problem. We have a lot of bone. It's a dental problem. The teeth are the torque. We have a palatal torque. So we expanded the upper arch. And then we want to prepare the case for prosthetic rehabilitation. And you can see I placed two mini screws in the anterior area to intrude the frontal part. Why I wanted to intrude? Because the upper incisor were over-erupted, and also the lower lip was covering too much the upper incisors. And we all know when we have a high stomion, the retrusion of the upper incisor will relapse, and we don't want to have that. And we wanted also to close the space and to change the midline and to bring the canines in contact with the centrals, and then the patient will go for prosthetic rehabilitation. And this is how we ended the case. You can easily see that we intruded a lot the upper incisors, and now she has to go to, we preferred to intrude more, not to see the gingiva for the incisors, because those are two crowns, and the gingiva doesn't look very nice, and also the length of the incisor will be changed by the prosthetic rehabilitation. Absolute intrusion of the posterior teeth. When you have a case like this, where we have the lower third, it's high, and we have a lot of lip incompetence, and we would like to close the bite, to close the lip incompetence, and change the profile. We can see it's a class 1, so it's a very favorable case. We had to control also the tongue thrust, and easily we can see that we have also a lack of space, more important in the lower than in the upper. The patient didn't want to extract teeth, so the option that we had, it was to place 2 TEDs in the lower and 2 TEDs in the upper. In the lower, we placed 2 buccal shelf screws between the molars, as close as possible to the arch level, so we could place elastics to intrude and distalize, intrude the molars, and to close the bite, and also to distalize a little bit to create space to align the teeth properly, and also to reduce the protrusion that we have in the lower arch. For the upper arch, we placed 2 JS screws. They are 2.0 diameter and 16 length and the tip, the tip of the screw was placed in the pterygopalatine area, where we have a very good bone quality, because we all know in the tuberosity we have a low quality bone, and to intrude the molars and to distalize the whole arch, we need a lot of anchorage and a strong bone. So with this type of screw, you can reach the pterygopalatine suture and use that anchorage to intrude the upper teeth. You can see how the treatment went, intruding the posteriors. In this case, I couldn't place the screw in the middle of the tuberosity, because when the wisdom teeth were extracted, we lost that part, the distal part of the bone of the tuberosity, so we could not place the implants there. So we had to place them. We placed them a little bit palatal. There are some issues with the biomechanics, because the teeth will tend to to rotate. The molars will tend to rotate, but we can correct that by placing elastics on the buccal part. And also we have to place the mini implants a little bit lower than the teeth to obtain the intrusion that we needed. And you can see how the posterior part, the molars in the lower arch and in the upper arch intruded. And we can see the bite closed without any vertical elastics. So this was a direct anchorage. And afterwards, usually when the molars are distalized and intruded enough, I would use my mini implants as indirect anchorage to hold the molar in place and to distalize the premolars, and also in the end to retrude the upper incisors. You can see here on the CBCT how we placed the screws. So they go from the tuberosity, from the end of the tuberosity, straight upwards and distally and palatally, so we can reach the pterygopalatine suture where we have better bone. And the lower implants were placed also in the buccal shelf, so they will not interfere with the intrusion and with the distalization of the lower teeth. So this is the case in the end. Without any vertical elastics in the anterior area, we used just light elastics in the end when we did the finishing, just to have proper occlusion and proper contact between teeth. And this is the end. And we can see on the lateral ceph that we closed the bite, we intruded the posterior teeth, and also we obtained a better inclination of the upper and lower incisors. And we accomplished our goals in this case. Absolute intrusion of the entire maxillary arch for patients with maxillary excess. This is a heavy and difficult situation, because for faster treatment we might address to orthodontic surgery when we have such a big maxillary excess. The faster way to go, it would be orthodontic surgery, but the patient didn't want it to have orthodontic surgery. She's a medical doctor, and she said, can we have another options? I said, yes, you could go to the true prosthetic treatment, to have gum surgery and then veneers and maybe some lip repositioning, and then you will not need any orthodontic or orthodontic surgery. But we have also another option to use plates. And you can see here we have a slide class 2. We placed the plates. We placed 4 plates, 2 on the right, 2 on the left. You can easily see the 3 hooks that we have. And usually for such a big intrusion, we need 4 plates. And you can see the way we intruded the upper arch. In this case, on the palatal side, we placed a palatal bar. Usually now I prefer to place TEDs in the pterygopalatine area to control the intrusion, because if we just place the plates and we pull just from buccal, the teeth will tip buccally, and we don't want to have that. And you can see easily here how we intruded, and we already cut 1 hook, and in the end we cut also the 2nd hook, and we have just 1 hook in the anterior area. And after the intrusion, we can correct also the sagittal problems that we have, and to change also and to have proper bite. And this is the end result after intrusion of the whole arch. And you can see we didn't lose any, or we didn't lost root size, even if we intruded such a big amount the teeth. And you can see here how we overlapped the STL file over the CBCT, and you can see how important is the intrusion that we had. You can see on the right corner also the section, how this intrusion went, because we overlapped the two CBCTs above the maxillary SNA, the anterior nasal spine and posterior nasal spine, and you can see the amount of the intrusion that we obtain with the plates. And this is a normal case that what we can achieve with such heavy, powerful tools like the mini plates, in cases where the patient doesn't want to have orthodontic surgery for such an important gummy smile. And this is the end after aesthetic reconstruction. So here you can see the changes between the initial and the final. We didn't touch the upper lip, so the upper lip didn't have any Botox or other surgical approach. So this is the exposure that we have after the intrusion. So the patient was very happy with the result, and the lip mobility also increased after we decreased the vertical height, and also corrected the occlusal contact. And also when you decrease the vertical dimension, usually the muscles tend to relax, and also the facial muscle will be more relaxed, and usually the mobility of the upper lip will change. Intrusion of the localized over-erupted teeth. In this case, the patient came from the prosthodontics, from the implantologist actually, because they started to do the bone reconstruction. You can see the reconstruction screws in the lower arch, and you can see also some TEDs in the upper arch. It's a class 1 patient. And also we can see the over-erupted teeth on the right side. Somebody tried before to intrude these teeth, but you can easily see that we have just 2 TEDs on the palatal side. And when you pull only from one side, the teeth will tend to incline to that side. So on the right side, we can see that the molars and the premolars tend to go palatally, and now the patient is in crossbite on the right side, and also the vertical problem didn't improve, and the patient wanted another option and another plan. So we placed an Anchorage plate on the right side, also to intrude the molars and to expand and to go with the molars a little bit more buccal to correct the crossbite. After the intrusion, we also corrected the small problems, aesthetic problems that we had in the frontal areas with the liners. And this is the end result that we obtained. The patient still has to change the lower crown because that's a provisional. And usually until the orthodontic treatment is finished, I ask the implantologist to place provisional crowns. And just after the case is done, I ask the patient to place the final crown. For transversal problems, when we need absolute anchorage, we can do maxillary expansion, MARPE, SARPE, or whatever we want to call it, and also unilateral dental alveolar expansions. Here we have slight class 3 patient. It's a young patient because it's 16 years old actually. You can see a mild class 3 but with maxillary deficit. The facial appearance, it's okay, but when we see intraorally, we can see we have a crossbite and a class 3 tendency. And because of the age, we preferred not to have normal rapid palatal expansion. We prefer to do maxillary expansion with anchorage on mini screws. And I placed 4 mini screws right in the suture. It's a very uncommon approach, but it worked to open better the suture, because I checked the suture before on the CBCT and I noticed that it was pretty closed, so it was not open. Usually in young patients, we will see the suture open. We placed a splint in the lower, so we will have no interferences from the occlusal contacts for the expansion. And you can see here the steps. I placed the mini implants. We placed the power screw. It's a very powerful screw. And you can see the result of the expansion. After finishing the expansion, I placed the transpalatal bar, and also one of the screws, I moved one of the screws from the anterior palate. I moved it in the pterygopalatine area to correct the midline. Anytime when I have issues with the midline, I use skeletal anchorage. I never use intermaxillary elastics to correct the midline. And in these cases, usually I use posterior TEDs either in the retromolar area or in the pterygopalatine area. It doesn't matter if it's lower or upper arch. And you can see here also in the lower arch, we place 2 retromolar mini screws to distalize the entire lower arch and to correct the class 3 from the sagittal point of view. In the beginning, for the lower molars, I use direct anchorage, and after the molars are distalized, and also I contracted a little bit the lower arch. After I distalize the lower molars, I place a ligature wire, usually thicker, a 0.12 wire, to do indirect anchorage, and also to distalize the premolars and the canine, and after that, in mass retraction of the frontal incisors. And this is the result that we have, and the patient is on braided wires because we are doing now finishing, and we want to close the space when we are almost done. You can see the sagittal problem corrected, the transversal problem corrected. We just have a rotation of the 1/6 that we will correct. In other cases, like this one, when we have a lot of missing teeth, with a lot of multiple agenesis, when we have a narrow maxilla, I don't like to use the teeth, a slight class 2. I don't like to use the teeth as anchorage for maxillary expansion. And we can see here that we have a crossbite on the left and a mild tendency to crossbite on the right side. So we wanted to have an asymmetric expansion. And in these cases with multiple agenesis, I don't want to use the teeth as anchorage because I want to keep the teeth and not to harm the teeth as much as possible, because anyhow, we don't have a lot of them. And we used TEDs for anchorage, and I placed 2 TEDs in the anterior area of the palate and 2 TEDs in the tuberosity because we had good bone in that area. We took the impression with the transfer abutments that Dream Medical company has for this type of JS screws, and this is a very good way to transfer the position of the TEDs for the lab. And the lab placed in the impression the analog of implants. So in the model, we will have the analog of implants, and then they can build this type of maxillary expansion screw that you can see here, anchored on TEDs and also on the 2 molars to control also the molars. And in the end, after the expansion, you can see on the right side, lower right side, we cut the wire that holds the 1/6, and we place an elastic chain to move the tooth palatally, because on that side we didn't need a lot of expansion, and that's how we achieved our asymmetric. Actually, in the beginning we did a bilateral expansion, and then we correct the excessive expansion that we did on the right. For sagittal movements, we can use skeletal anchorage for space closure from mesial or distal, protraction of the entire arch or mesialization of the molars, retraction of the entire arch or distalization of the molars, midline corrections, and orthopedics. This is a very important topic because we can use skeletal anchorage in many ways and with different mechanics. Space closure for mesial, in this case with missing laterals because it's a young patient, and we have also the 3rd molar. We preferred to mesialize the whole upper arch and to close the space. And then when the patient is an adult, she can do prosthetic rehabilitation in the frontal area and to change the aspect and to improve the aesthetics. In this case, we used the device modified, anchored on 2 TEDs on the anterior part, with 2 extensions that we will do indirect anchorage on the centrals after we close the diastema. And for mesialization, we used 2 Hicon screws. It's an uncommon method, but this method works well if it's done together with a fixed appliance with braces that are placed on the buccal. So we will also use the indirect anchorage on the frontals and the direct anchorage with the screws for the molars. So we will work in tandem, palatally and buccally, and we can see how the spaces close easily, and it's a work in progress. Protraction of the entire arch or mesialization of the molars we can do also for adult patients. And in this case, this patient, it's a dentist that wanted to correct the mild class 3 that he has. And he wanted to close the upper spaces and not to have implants. So we wanted to move the entire upper arch a little bit mesial and to close the spaces. We placed the braces, we placed the TEDs in the anterior area on the suture, because in the suture we can place longer implants. So these are JS 2.0, 2 millimeters in diameter. You can see here the transferring abutments for the impression. And we took the impression, sent it to the lab, and the lab prepared for us this device that we used for indirect anchorage on the incisors and direct anchorage for the molars. And because he lives in another country, I preferred, and he's a doctor, I preferred to give him elastic to change the elastics by himself. and not to come so often. And now during this pandemic, the treatment goes on, and we check just we do just telemedicine, and you can see how we close the spaces, and it works pretty well, pulling from buccal using the incisors and as in the indirect anchorage, and also from palatal to mesialize and close all the spaces. And in the end, we cut the arms. We opened a little bit of space in the lower arch because here we have a lower incisors that it has a morphological problem. Another option to close the space when we have missing lateral and the mild class 2, we can use this type of appliance with anchorage in the anterior area of the palate. And in this case, we used the coil spring type of appliance to mesialize the molars, and also the indirect. After we will correct the position of the centrals, we will use also the frontal area, the incisors with indirect anchorage to close all the spaces. Retraction of the entire arch and distalization of the molars we can do very easily with the same type of appliance. In this case, we see we have a crowding, and we wanted to correct this crowding by distalizing the molars. And we place 2 TEDs in the suture, and I like a lot to distalize molars when I don't want to change the vertical, or I would like to open the vertical. I prefer to use screws because they are more reliable than the coil spring type of appliance. And whenever I have the option to use screws, I will prefer to use screws and not the coil spring type of appliance. And you can see very nicely how much space we opened here for the premolars and the canine, and how nicely they are coming in. And we will correct the class. We corrected the crowding, and now we have to correct the class 2. And you can see here how the TEDs are placed. It might look that the TEDs are in the sinus, but actually they are in the suture. In 2x2 cases with diminished lower vertical height, and you can see it's an important class 2. We have an AMB of 6.4, and with a lower deficit. So in this case, we wanted only to distalize the upper arch, and this was a difficult case because the mother told us you will not have a lot of cooperation from him. So we had to use any mechanics that we could use not to have the patient compliance. And you can see we have an important class 2 with a deep bite. It's a very typical class 2x2 with 1 cusp, very important 1 cusp distalization. And in this case, we placed 2 JS screws, 16 in length and 2.5 in diameter, because it's a young patient, and we know that young patients have a poor quality bone. This is one of the only cases, I think it's the only case that I placed the TEDs before the molar extraction, and it worked wonderful because I could use the TEDs right after the extraction and the treatment, because right after the extraction, we all know we have some wrap effect in the molar area. So in a radius of 10 millimeters around the trauma, usually we will have a wrap effect. So I could distalize the molars very fast after the wisdom tooth teeth were removed, and the upper arch distalized very well, and we could correct the class 2 very easily and very fast. I used an anterior plate just to open the bite and not to increase the vertical dimension, because the lower third was diminished, and to improve the facial appearance. And you can see very nicely how we could correct the class 2, and we corrected also the bite, and also the facial appearance improved. We just left some spaces for prosthetic reconstruction in the future. When the patient it will be adult, he will have veneers, but for now he will just have some composite restoration to close those spaces. And you can see how the skeletal and dental changes look like. The same approach we can have also in lingual cases when we want to correct this type of problems. It's a mild class 2 and nice facial appearance, but we can see we have a missing 3-6, and also on the left side we have class 1 on the molars and distalization on the canines. And pretty much the same mechanics we used on Buke with vestibular brackets, we can use with lingual also. And with elastic chains, we distalized the molars, the premolars with direct anchorage. And afterwards, also we closed the spaces in the anterior area, and we corrected the bite very nicely, and the teeth are aligned, and we opened the space for the implant for in the lower for 4-6, and we corrected very nicely the problems that we had. So it doesn't matter if it's buccal or lingual, it's the same mechanics. In this case, what we do right now in these cases for young kids, if they cannot, because they cannot travel so much, so we had to shorten to do less appointments. In these cases, usually now we use digital planning. So we will have a CBCT, and we will send the CBCT and the scan to the lab, and the lab will place virtually the TADs on the pallet. We will have a surgical guide, and we can do, they will do also the bands digitally. So this is the lab that help us to do all this work, and it works really nice. You can see here in the beginning, first we checked how the appliance fits into the mouth. So we wanted just to distalize the left side and to hold the right side to correct the class 2. We placed the brackets, and then we checked the guide, how it fits. We checked also the key, how it fits into the holes, to be sure that we can screw the TADs. We usually do a very small anesthetic just locally, and then we place the anesthetic through the guide, just in the place where we'll place the implants. And you can see on the right area, just the mucosa, it's a little bit white in that area, and that's the whole anesthetic that we place in these cases. We check the guide how it fits perfectly, and then with orthonia, it's very easy to place the TADs through the guide. I would love to ask jail company to produce another key that doesn't have that rubber band that holds the screw, because usually after a few cases that rubber band will rupture, and it will not hold the TED properly. So we place the screws and the appliance fits perfectly. We check again how the appliance fits, and we see we have enough space to place the cement, and then we cement the appliance in, and we go on with the treatment. Another case that's a very nice case with where we distalized the upper arch and intruded the upper arch, and we mesialized the whole lower arch. So distalization in the upper and mesialization in the lower, and also intrusion in the upper arch to close the bite, because here we had an open bite, a class 2, because the patient extracted the 3/6 and 4/6 in the past, and the space closed, but also from mesial and also from distal. And she ended up with this anomaly. So we wanted to open the space for the upper molar. And you can see it's an important class 2, and also an important open bite. And in the past, I would usually send this type of cases. You can see here the mounting in CR, how the case looks like. In the past, this type of cases I would send to orthognathic surgery, but the patient didn't want to have orthognathic surgery. So here we did the setup, and with auto rotation, we noticed that we can correct by intrusion half of the distalization, and half a cusp we will have to use distalization. So that's the end result that we want to obtain. We did the indirect bonding according to the setup. And then we placed 2 anchorage plates in the lower arch in an anterior part. This was one of the first cases of mesialization of the lower arch, and the surgeon forgot to cut the 2 hooks. In these cases, I would highly recommend just to use 1 hook, not all 3, because these hooks are a little bit elastic, and when you put a lot of elastic chains on the hooks, they will tend to bend. And so I would recommend just to cut those 2 first hooks and use just 1, and place the plate a little bit higher. So here you can see how we started to mesialize the lower arch, and step by step, usually 2 teeth at a time on each side, not to overpower the arch wire, because we need a strong stainless steel wire, because when you pull only from the buccal and you want to mesialize the whole lower arch, usually the arch tends to widen, and in the end you can end up having a crossbite, and we don't want to have that. In the upper arch, after correcting most of the mesialization in the lower arch, we started to work in the upper arch by placing 2 TEDs in the pterygopalatine area or in the tuberosity. And first we used direct anchorage to open the space for 1/6. You can see the lower arch, it's closed, and it looks very nicely. And also to distalize the 1/7, I used indirect anchorage for the premolars with the ligature wire that you can see, and also a coil spring on buccal, and we pulled palatally the molar with the TAD, and buccal we pushed the molar with coil spring. This is the position of the TADs and the plates. And now we have enough space to place the implants, and I love to have the implants as soon as possible because I like to use them as anchorage. For my case, you see how the bite closed just by taking the lower molars from the occlusal, moving them forward, also away from the distal part of the mandible, and so the mandible could auto-rotate and intrude a little bit the posterior upper molars. You see how nicely the bite closed. Here you can see the TADs, JS, 2.016 in length. And the patient had to marry, so we had to take off the upper arch because it was finished. And we had to keep the lower arch because by mistake she broke the arch wire and the lower molars rotated a little bit, and we had to keep the lower brackets a little bit more. And you can see how the facial appearance improved, how the smile improved, and also the bite changed, and we have very good occlusion and stable result. And you can see very easily in the beginning she didn't like to smile, and now she cannot close her mouth, and not because we opened the anterior third, just because she really likes how she looks. And this is how the end result looks. And you can see here really nicely how the mandible auto-rotates and how we managed to improve the open bite by intruding the upper molars and also mesializing the lower molars. And we can obtain very nice results with these anchorage devices that we have. Also, we can use anchorage plates. This is the last case. We can improve the facial aesthetics, and we can treat anomalies. Also, we can do orthopedics in class 3 cases with cleft lip and palate, like this one with important maxillary deficit. This case came to us with braces in the mouth, and we had to remove them, and no orthopedic treatment. They were just trying to align the teeth, and I don't know what else they wanted to do. So no orthopedic treatment was done. So we placed 2 plates in the upper, 2 plates in the lower. And with maxillary protraction, 24/7 elastics, we managed to improve very nicely the class 3. And now we removed the palatal expander and we placed braces, but you can see easily how the class 3 improved, and we corrected the maxillary deficit. So skeletal anchorage devices are successful, improving function and aesthetics, less invasive and expensive as orthodontic surgery. We can also have better results with skeletal anchorage for when we have no compliance and we don't need any compliance from the patient. We just have to be careful to plan well, to think our cases in the 3 planes of space, and to choose the proper mechanics to obtain a good result. Thank you very much.